Okay. Hey guys, my name's Kathy. I'm the lead intake and marketing specialist here at Support Inc. So grateful to have you guys join us today. I just want to thank everyone for taking some time out of your busy Tuesday to catch up with us and to watch this presentation from our clinical team. With us today is Chris Sharkey. He's going to be our expert leading the charge on this conversation. I'm going to go ahead and share my screen in just a moment. And then we'll get started with introductions on this webinar. Let's see here. All right. Can you guys see this okay?
Yes.
Yep, we can see that.
Okay, thank you. All right. So once again, thanks again for joining us. My name is Kathy. We're going to be going over our clinical services. So if you weren't here back in 2021, I believe this was the very first webinar that we kicked off about 5 years ago. And so we just wanted to revisit this topic as a lot has changed in the last several years. The purpose of these webinars is just to keep our constituents informed. And so we thought that this would be a good opportunity to bring people up to speed on what different departments and whatnot are up to. Let's see here. This says types of clinical services at Support Inc. Chris, can you see and hear me okay?
Yep. Yep.
All right, I'm just
Um,
going to go ahead and kick it over to you to introduce yourself and get started.
all right. Well, yeah, I'm Chris Sharkey. I'm the Associate Director of our clinical team here at Support Inc. I've been here a little over 7 years, and working with the clinical team on all kinds of different services for our individuals. I also am joined by Ashley, one of our clinicians here as well. So she'll be jumping in with any additional thoughts and maybe some anecdotes about kind of her work with her clients and kind of what that looks like. But yeah, just to give you an overview of our services, and then we'll kind of go in more detail into each kind of area more. But everything that we're doing in our clinical services here at Support is under that person-centered and trauma-informed lens. That's really where we base all of our work out of. And then through that, we do different types of assessment, clinical consultations, individual and group counseling, and we'll go into that more here. So kind of just expanding more and just person-centered. It's a phrase that gets thrown around a lot. You've probably heard it before. You might have even done trainings on this before. And it is something that at face value can be pretty straightforward and simple, and it makes a lot of sense. But really, when you are really trying to apply this, it becomes a much more involved intervention and something that can be used in all of your interactions with somebody. So person-centered therapy really uses that non-authoritative approach that allows clients to take more of a lead in discussions so that through that process, they can discover their own solutions. So really the goal then as a therapist in this situation is to be that compassionate facilitator. You're doing your best to listen and really hear them out because you need to fully hear what they're saying. You can't be coming in with your own judgments or preconceived notions. You need to really be curious and learn more about where this person's coming from and why they're feeling this way, why they want to do this. And in doing that, you're really helping just follow them in the conversation versus trying to get some predetermined outcome or what sounds better to you. You're really avoiding that. You want to let them, really be the one in charge and guiding that discussion. You're there to encourage and support the client and really guide the therapeutic process without interrupting or interfering with that process of self-discovery. A lot of times you might come up with a solution to a problem or something that's going on in someone's life, and there's more than one way to solve it, though. There's not always a perfect solution or correct way to learn a new skill. And really, by going through that learning process, that's how you create meaningful changes. That's how you create new ways to help yourself in that self-discovery process. So then ways of then helping that client become the expert in their session, something that we're really focused on in our clinical work here. Um, for someone to have success in therapy, it really relies on these conditions. That unconditional positive regard, that's the idea of being empathetic and non-judgmental to help convey those feelings of trust, understanding, and confidence, which then allows someone to make their own decisions and choices. It gives them that secure base to be able to do so. When you're empathetic and understanding, that means you're working to completely understand and accept the client's thoughts and feelings. You don't always have to agree with it. You might think something else might be a better way to solve a problem, but you're accepting that that's what their choice is. That's what they want to do, and you're going to work to support them towards that. And then congruence. So that's that idea that you're not carrying any air of authority or professional superiority, but instead presenting yourself as true and accessible as possible so that your client can see you as honest and transparent. Not coming in with, hey, I've got a counseling degree, I've got all this training, or I've got these interventions that are, fancy and I'm going to fix things. You don't come in with it with that you really are approaching it of, hey, we're working together. I need to understand you. What do I need to know about you, and how can I help support you through this? And really making them feel comfortable throughout that discussion and that process, because that's laying all the groundwork then to be able to do the actual work in sessions.
Hmm. Love it.
And then a lot of this is getting at the ideas of, you know, when you're working with somebody and they've had issues or there is some type of challenge that someone's experiencing right now, really kind of thinking about how you talk to somebody about something that's hard. Do you ask them what's wrong, or do you ask them what happened to them? That might not seem like it really matters, or it's asking the same thing, but it really feels different in a conversation when someone's asking you these different questions. So when you're providing trauma-informed care, you're working to recognizing the pervasiveness of trauma in the world. And unfortunately, in the world of IDD, trauma is very pervasive. It's very common, and it's something that we need to be aware of when we're working with this population, because we do want to be, as aware as possible of anybody's personal or societal consequences through their life that they've had, anticipating how trauma survivors may respond to our words and actions, and doing our part to create a world that does not cause further harm. A great example of making sure, like, our, paying attention to our words and what they could mean to somebody. I worked with a client and their host home provider years ago, and it was somebody who had moved around a lot in the past year. I think they'd been in like 3 or 4 different host homes in a calendar year. And by the time we got to this third or fourth host home, um, they were kind of going through an issue with their host home provider. It was something about just like how things were set up in the home, and what they like wanted to be able to like kind of get their kind of space set up as. And the host home provider just mentioned, like, hey, if you don't like my house, if you don't like my setup, you can always talk to your team if you want to look at other homes. And that individual took that as, my host home provider is kicking me out. They're telling me I have to go now, even though in the conversation from the host home provider's perspective, they were trying to be supportive and positive and offer a good choice of, hey, you have choices, you can go do this. But they viewed that as being kicked out due to, in the past, they had been kicked out of homes. They had had to move suddenly or without their choice. So even just wordings like that in a conversation can send different messages than we intend. So it's kind of always like looking at how our communications are going, checking in, getting feedback from the person, as well as just being aware and, doing your own self-reflection after your interactions with somebody. So we do that a lot after our sessions of, hey, what went well? Was there anything else that I'm missing? Was there a part of the session that maybe I could have done more or I could have spent more time on? But we're examining that so that making sure that we can help create and strengthen those relationships and, create that safe space in our work. And then more of those principles then as a part of our work, that you must have safety. You have to be trustworthy and transparent in the work then. Working to have peer support as well. That's another huge thing in our world of services when we're trying to help somebody create their own self-sustaining system for themselves, that they're not reliant on paid caregivers or other paid services, that they're creating their own peer network, their own, network in the community of people that can support them. That's really important for somebody to be doing well, and being able to have that safety. And then working together with collaboration and mutuality, making sure that someone's empowered and that you're hearing their voice and allowing them to make choices. And then considering any other type of things to consider, anyone's cultural history, cultural concerns, historical histories, or any gender issues or anything else that might go into someone's life, into their experiences and where they are now and who they are as a person today.
Mm-hmm. Yeah, I definitely think safety stands out to me, especially when you're wanting to have a quiet, private space for someone to talk as well. So whether that's in their bedroom with them or maybe out in the community away from a provider, so they can talk in private and express their true concerns. I think that's something that the clinical team does a really good job at as well, as just meeting people where they are. So whether that's in the home or in the community, just making sure that their privacy is respected for sessions as well. So.
Yeah, yeah, and that's a good point, Kathy, that yeah, you can kind of have different types of sessions depending on where they're held as well. That going for a walk around your neighborhood is typically a lot different than sitting with someone at the kitchen table in their home or, or other places like that. So really making sure that someone gets a choice and hey, where do you want to meet for your session? That we really try to work to honor that. And some of our clients discover that hey, a phone session is easier for me to talk about tough things than in person face to face. And we kind
Mhm.
of start to learn that about someone's preferences and what helps them to get the most out of their counseling.
Mhm. And then an option for people as well.
Oh, I'm sorry, could you say that again, Kathy? It broke up.
Online sessions, like if somebody wants to meet online because maybe they're not feeling well, I think that's an option as well.
Yep, yep, yeah. Over
Yeah.
both Zoom or Teams video calls that we can do those as well. Yep. Okay. So then getting into more of the specific services that we do, these are the things that you get units, and we'll talk more about that towards the end of how we get the services added to someone's plan. But the assessment service that we do, it's utilized to complete assessments, as the name implies, and helping us create our treatment plans. The treatment plan then is driven by symptom areas highlighted by the assessments, with the therapeutic interventions tailored to the individual needs. And then also, of course, that we're taking in interviews with the person, anybody else who might work and support with them, and we're taking all of that information into our treatment planning as we're helping someone to pick out the goals that they want to work on.
Hmm.
And then through consultation, this is a broader category, and these are utilized to help our clinicians meet and discuss with anybody on the person's team, including their host home provider, family caregiver, case manager, job coaches. Sometimes we might talk to their psychiatrist, day program teams, anybody that might work with somebody, ARC advocates, really anybody who's involved in supporting somebody. And when we're working with the teams to make sure that everyone understands what someone's goals are, what their treatment plan is, and if there's any specific interventions that anybody who works on their team can utilize with that person to help to them towards those goals. So helping, either just help a team understand what intervention is important at home or at a day program or elsewhere or at their job for supports, really making sure that everybody is literally on the same page and knows what's best to help somebody. And that if there are changes or new concerns popping up, that we're all communicating and working together to help support this individual. And then individual counseling, that's our main service area that we do the most of. And those for counseling services, then those are just what you think of as anywhere from regular counseling sessions of anywhere from half hour to an hour long per week. Some people, though, their preference is completely different. They like shorter check-ins throughout the week. They would prefer to do short 15 to 30-minute sessions and then break it up into multiple sessions, or have bi-weekly sessions or once a month sessions. But we're really focusing that frequency on, from that assessed need and the person's preference for what they actually want to do. Um, it is really easy for someone's life to get filled up with lots of appointments and a busy schedule from working, day program, volunteering, or other activities, or exercise or sports. And all of a sudden, I'm the sixth person today in the afternoon who's asked them how they're feeling, if they need support with something, and they're probably just talked out from a long day. So then helping somebody then express that, hey, I don't want to talk to you today as well. That's okay. That's something that we want to empower people to be able to say, hey, I don't want to talk today. I'd like to cancel my session. We want to support that just as much as we want them to talk to us. But yeah, really more of that choice and preference for where they meet, like we talked about before, as well as really working together on any current treatment plan goals. And that can really be a really wide range of things that we work on, from coping skills, social skills, and really just anything in between related to their diagnoses or specific concerns such as maybe safety with either self-harm or suicidality, physical aggression, things like that as well.
And I feel like counseling can be kind of a tricky spot for families and clients coming into services. Like, hey, this isn't necessarily like traditional talk therapy. It can be if that's what they want. But I do some of my best work by playing a game of Uno, talking about their favorite sports team and engaging them and figuring out, going through their feelings and emotions through things other than just talk therapy. So like it can be very creative and engaging in other ways and just sitting down and having a conversation as well. So I think that's where sometimes people get hesitant when they come into services like, well, I don't want counseling. I've already been counseled or that sort of thing. It's creative. It can be creative and we meet everybody where they're at and their individual needs.
You
Hmm.
No, no, definitely. And yeah, even thinking of those first few sessions, that rapport building, it might look, different than what you think of as that traditional intake session when you go to the, office and fill out, like the little check sheet of, areas of concern or current symptoms and stuff like that. We get an intake form, we get, a referral. But really just sitting down with somebody and having those first few sessions to let them tell you about them versus just reading their chart, that you really learn a lot about somebody through their own words that way. And really not forcing the session to be like, all right, well, today we got to do that first assessment. We got to get that done today. It's not always on a strict timeline like that, that we're really going at someone's pace and what they're comfortable doing. And they might need a few introduction sessions just to get comfortable talking to us. And we want to accommodate that.
Hmm. Yeah, I feel like the individual counseling sessions is the bread and butter of what you guys do, so to speak. And I also think it's important to distinguish these services from other services in the field because oftentimes people think about counseling and they just assume it's ABA, but you guys go beyond that, right? Like with mental health interventions and whatnot.
Yeah, yeah. So yeah, we really do utilize a blend of all of that. But we do some more behavioral focused interventions, things
Hmm.
even things on like, helping somebody learn, new like communication systems or strengthen existing communication systems that they might use, and things like that. As well as, yeah, we might be focused more on, hey, your depression symptoms are getting worse, and we need to work in coordination with your psychiatrist and your team to help manage these symptoms, and working towards that. Yeah, it really ranges. Okay. And then yeah, group counseling. We do this kind of throughout our regions that we do, typically more seasonal events and stuff like that. Um, And yeah, our groups range wide things that we do with those, and we try to target really just different areas that our clients are giving us feedback on, things that they want to get to practice and do in the group settings more and more. So we've done different things in person as well as online. We've done things, and kind of the base of all of our groups is we design all of them to just give a good, positive social environment for those interactions, that we're helping everyone who's joining the group to be ready to, interact with each other and hopefully just make some connections as part of the groups. And then whatever the actual group topic is on, that's, almost the secondary intervention sometimes, that just getting people connected and knowing that there's other people out there in their world, that can lead to all sorts of good, positive outcomes for people just connecting with somebody. But then, of
Hmm.
course, yes, there are things that we're practicing, whether it's, being able to navigate in your community, but it's a lot more fun to do that as a group. If you're working on emotional regulation skills, um, getting engaged in current events or your community areas. I mean, the groups really evolve a lot. There's always some type of clinical base for the group, whether it's what it's targeting specifically, but really trying to go by our client feedback of what's an activity that you would like to do, and then how do we then turn that into a clinical intervention. That's kind of how we do that, kind of thought process with it.
An
Nice.
example of a group that we've done is like Moving and Grooving, it was called. And it was a lot of our individuals need extra support on like exercise and taking care of their physical health. And obviously, you go to doctors, you need to lose weight, you lose weight. Well, that doesn't always feel good for them to hear, right? And so, like, we came up with a group where we listened to music and we went to parks sometimes too, and we moved our bodies together. So I was like, well, we're not alone. We all need support of moving our bodies and that exercise and that engagement. And that made it feel like it was more fun than just like, well, I need to lose weight. So I'm just going to sit in my room and do some workout video for an hour, which doesn't always feel like it's effective. And so
Mhm.
that was just a way that we did a moving and grooving. So that way everybody's kind of open, like, yes, this is a goal we all have. Now let's do it together and make it a little bit more fun and relaxing.
Yep.
Hmm.
Yeah, no, exactly. And that's where, yeah, you can just kind of start taking in, yeah, what am I noticing? What are people needing or wanting to do? And then, yeah, how do I actually turn that into something that, I would want to do, what I would want to go join in on? How do we make this, appealing to somebody to work on something that might be hard?
Yeah. And moving beyond limitations as well, because we know that a lot of people have to use wheelchairs and whatnot. Maybe their mobility is limited to a certain degree, but that doesn't mean that you can't do like upper body stuff or like how can we still help you reach your goals despite your current circumstances? So,
Yeah, it's very easy to adapt to each individual needs for sure.
yeah, I've seen you guys do it, and I think y'all are excellent at it.
Right. So then, yeah, if you're thinking about clinical services for somebody that you're a caregiver for or somebody that you know, oh, okay, and I just actually just saw a question from Christian in the chat. So if somebody wanted to go fishing with their clinician during a counseling session, is that allowed? It could be. It would probably be a matter of finding a spot that's where you could meet, in the Front Range area, since, we are limited on how far we can drive. But we'd have to, yeah, find a spot. And then really the only other consideration for that would be, yeah, how private is that spot? What, conversations around confidentiality, might we have to prepare somebody for if they're choosing to have their session, at a public park area or something like that. But yeah,
And of course, how good is the fishing in that spot?
wow, I would say if someone's suggesting fishing, they've probably already got their spot picked out, right? So
Yeah.
they've got the spot. Um, but yes, and let me just double check to see if there was anything else in the chat so far. Okay. All right. So then, yeah, if clinical services sound like something that either for someone that you're a caregiver for or someone that you know or work with, a couple different ways to kind of get that service started. One, you can contact your case manager. Some counties also refer to them as resource coordinators, or there might be a few other terms just across our state. But you can ask them to request clinical services to be added to your service plan anytime throughout the year or your annual service plan meeting. You can also talk to your team at Support Inc. Your residential program coordinator, or abbreviated as RPC, can help you make that request for clinical services to get those added to the plan. And then also, if you're brand new to our services, you can talk to your intake coordinator about including clinical services in your service plan as well. But if you have any questions or just are wondering about it, you can contact any of us here at Support, and we can help get you in the right direction to answer your questions, or get you connected to the right person as well.
Cool. Awesome. Thank you so much, Chris. That was super helpful. Ashley, was there anything else that you wanted to add to that?
No, I just think that there's room for discussion for each individual needs. We can get creative. We're happy to take on people, and yeah, I mean it's a fun group of people, individuals that we work with, and we encourage people to give it a try.
Mhm. I think one thing I wanted to point out, because sometimes people are new to the DD waiver and they have questions about like the funding sources and things like that. So one quick thing that I wanted to point out is if you're a family caregiver or host home provider, these services don't come out of your pay. This is kind of like a separate pot of money, so to speak. So that's just something to be aware of. And it's at no cost to the person that signs up for services. So. And I think the other thing I wanted to mention is that a lot of folks on our clinical team have excellent experience. I'm pretty sure everyone's required to have a master's degree. Most people have their LPC. I think we have one person with an occupational therapy degree. I can't stress enough that it goes beyond ABA because I feel like when people hear behavioral services, that's what their mind immediately jumps to. But I mean, am I speaking out of turn, Chris, or is like it's also mental health interventions, not just ABA and whatnot?
Yep. No, it really is. Yeah. Drawing on what does somebody need? What are they wanting to do? And then, yeah, is a more behavioral based intervention the best option for them, or is it a more mental health? However, typically it's usually a blend of both. It really is that there might be a behavioral concern that we're working with, as well as their mental health. And those really work together. I really see them as kind of one and the same, that your behaviors influence your thoughts and your emotions and vice versa. So really, you're really working with the whole person.
And unfortunately, we haven't found a magic wand, so we cannot change behavior overnight or change behavior altogether. But we support them to change to offer change a little bit over time. And sometimes it takes a long time, and sometimes behavior gets worse before it gets better. But that also means that something is working with what we're doing. If you see it to get a little bit worse, because it does get better over time, but it just doesn't happen overnight, unfortunately.
Hmm. Yeah, just setting realistic expectations for services. Is that called an extinction burst? Like sometimes things get worse before they get better, and that's
Um,
pretty common.
yeah, yeah,
Yeah.
but yeah.
Yeah, I
And
feel
we'll
like
rule out
Ashley.
medical stuff before, like sometimes we say, okay, take them to the doctor. We might think they have an infection. We like to rule out medical before behavioral because we often see like they work together and like somebody might have a UTI and it shows extreme behaviors in some people. So we work closely with the nurse team or with their doctor and say, hey, take them in to get their urine checked. We think they might have a UTI or they might have a tooth infection. So
Mhm.
there's kind of, that dual working process that we work with their healthcare team and along with us to see maybe it's medical, maybe it's not.
Mhm.
Hmm. I was
Oh,
literally thinking UTI right before you said that. Yeah, I think Ashley, you've been here like 13, 14 years, so you've been doing this for a while. Do you have examples of like maybe, without compromising HIPAA, obviously, but just like common concerns or any sort of symptoms that people come to you with? Like, would you say depression and anxiety is pretty common, things like that?
I'd say anxiety and like communication, being able to communicate what they're feeling is they're not able to identify emotions or words of how they're feeling. And so working with them on that and developing those words for them to use and those feelings that they're able to use are the big ones. Anxiety, social skills, like wanting to be involved in the community more and not having those relationships. Like a lot of us are they're people in their life that are paid staff. They don't have family members like we all do can go home to. Some of them just they're post home providers are their family because they don't have people involved in their life. So they want to be more involved
Hmm.
in the community and be wanted and cared for.
Hmm. Yeah. And so just to rehash, the main services that we provide here at Supporting is going to be that residential piece. We work with family caregivers, host home providers, and then individuals living on their own in the community. So you can imagine how effective clinical services can be, right? Like when someone comes to us, maybe it's a paid mom or an uncle, whoever. It's like we can help family caregivers with the consultation piece, for instance. I would imagine that we've helped clients when they're moving from one host home to the next. Maybe there's some trauma there that needs to be rehashed, and then also people that living on their own independently in the community. I think clinical skills can be really helpful in those situations as well. So,
yeah. And then I saw a question from Christy in the chat about asking more. So yeah, it's an extinction burst. So that's a term. It's more of a behavioral term. But that gets at the idea that when you are changing a reinforcement, so just for like a quick example situation, that'd be like, let's say every time somebody yells, you give them a snack. So that's what they've learned to get a snack is that you yell. And then if you're trying to then change, yelling for a snack versus asking for a snack, like, can I have something or can I have some food or can I have a snack? And you're trying to teach that actual specific question, then you wouldn't respond when they're yelling. You would only respond when they're asking that question now. And when you're implementing that right away, they might ramp up the yelling more and more, trying to get the snack and get that needs met until they're able to then practice and work enough through prompting and reminders and modeling of, hey, you can ask for this versus yelling. So you might see an increase of the yelling behavior until they're learning the new skill of asking the question instead.
mhm. Awesome.
Good
Is there any other
questions.
questions? Yeah.
Yeah, no, good questions. Great presentation. I'm Brian. I'm Director of Intake at Sporting. Been here for 7 years, and I feel like I just learned new things, which is always awesome. So thank you. To add on to what Kathy said, also our day programs, our clinical team, our clinicians help a ton at our day programs, run
Hmm.
groups at our day programs. So that's awesome. And I've always appreciated that we call it clinical services.
Hmm.
I came from case management, and behavioral services kind of indicate you have a behavioral problem when I feel like anybody, all of us can benefit from clinical services everything you both described today. So just wanted to point that out. And yeah, thank you both.
Mhm. Yeah, I know on the front end with intake, we're always encouraging people to tap into the clinical team. It's definitely a resource that we want to utilize internally whenever people choose to opt into it. So, love this bunch. Is there any questions about clinical services or maybe how that piece interacts with the day services, anything like that? If you guys haven't heard the drum we've been beating for a year and a half now, we did expand services all along the Front Range. I think we opened up like 7 offices in a year, something like that. It was insane. Now we have day services in all these new locations across the Front Range, and the benefit is that clinicians can tap into those new meeting rooms and whatnot. So if you ever know somebody needing clinical services, that offers a new opportunity to land in a new spot for people. So. All right. Any questions before I wrap up the recording?